Today, however, I've been asked to focus more on the issue of genetics and planning for a family. I asked my wife whether I should say this. The thing with genetics is that people automatically think about genetics as being prenatal testing and terminations of pregnancy. So because of that, and I realise that some of these issues that I'll be discussing are not necessarily comfortable for some people, and they don't necessarily reflect my personal views either. So if you're uncomfortable with some of the topics that I mentioned, then please feel free to leave and I won't be offended. What I plan to do, though, is to talk a little bit about the inheritance of myotonic dystrophy, which hopefully most of you will know, but I still think we need to cover it. I'm going to talk about the phenomenon of anticipation, which is where myotonic dystrophy gets worse going down the generations. And then I'm going to talk about genetic testing in pregnancy, traditional forms such as amniocentesis and chorionic villus sampling, which is CVS, and also newer technologies, which is cell-free fetal DNA, and we've already mentioned PGD, pre-implantation genetic diagnosis. Well, that's excellent. There was more on that slide. So whether or not that's going to bode well for the formatting of some of the other pictures, this was supposed to show one of, if those of you who know David Brooks, that was going to be a picture of an egg, where there's a white background with a nucleus and chromosomes in it, but something's happened to the format, so I don't know what's going to happen to the rest of it. Oh look, there we go, it is there. Excellent. What I wanted to mention as well is from the nucleus, we have lots of chromosomes. So altogether we have 46 chromosomes, but they come in pairs. So there's 23 pairs of chromosomes, and the chromosomes, if you unwind them and unravel them, and I'm going to get into trouble from walking away from here though. So this is the chromosome. If you unravel the chromosome, eventually you come down to the gene, and then eventually if you carry on looking at it more closely, you look at the letters, the code, the CTGs and the A's. But I need to emphasize that you have 2 copies of every chromosome, so you have 2 copies of your DMPK gene. So the gene associated with myotonic dystrophy is the DMPK gene. So everybody, I have 2 copies of the DMPK gene. Everybody in this room has 2 copies of the DMPK gene. Now in dominant inheritance, what happens is one person has got a fault on their myotonic dystrophy gene. We know it's a CTG repeat, but the fault is that star there. Now, what happens in the vast majority of situations is that 2 people, one person doesn't have myotonic dystrophy, so that's the person on your right, and the person who's got myotonic dystrophy has got 1 normal copy of the gene and 1 altered copy of the gene. And when they have children, then that individual can either inherit the normal copy from both parents, and therefore they won't have myotonic dystrophy, or they can inherit 1 altered copy and 1 normal copy from the unaffected person. And that basically happens 4 times. So in 2 out of 4 people, they will have inherited the altered gene from their parent, and therefore with each pregnancy there's basically a 50-50 chance, 50% chance, 1 in 2, whatever you want to say, it is basically a 50-50 chance in each pregnancy of passing on the myotonic dystrophy. But of course, it's not quite as simple as that. Now, as a geneticist, I'm used to doing family trees. So if you're not used to family trees, then squares are men and circles are ladies. And what this shows is grandparents at the top, and then in the next generation there are 3 people who are affected. They're the people who've been filled in black, and the unaffected people are the people in white. And then down in the grandchildren's generation, sadly, one of the grandchildren has passed away. What this doesn't show, though, is that actually the myotonic dystrophy has got worse going down the generations. And that's what we mean by the term anticipation. So it seems to get worse and start at an earlier age, the subsequent generations. So you'll see the grandfather had cataracts at 56, but no other problems at all. And if he'd been to see an ophthalmologist, the ophthalmologist would have said, well, that's not particularly young. He wouldn't have guessed that there was anything problem with myotonic dystrophy. And it's only when his children were born, and then later in their life, they started to develop weakness. So this person had cataracts and weakness on the far side. And then her sister had myotonia and mild weakness as well, although her weakness was earlier, in her 20s. But she had no problems in childhood. Sadly, she had 2 children affected with myotonic dystrophy, one who didn't even survive. And it's often when you get to this point that myotonic dystrophy is diagnosed. It's not even diagnosed in this point in some families. It's when this child has sadly passed away or been diagnosed with myotonic dystrophy that this lady then gets diagnosed, and then subsequently the grandfather gets diagnosed. And that's the classic situation actually in about 2/3 to 3/4 of families. It's actually a grandfather to daughter and then congenital myotonic dystrophy. So really the question is how can we prevent it? And this is one of the families that I've been dealing with for many years, and everybody on this picture has myotonic dystrophy. So there's John with his sister who doesn't really look like she's got myotonic dystrophy, and his mother sitting in front of him, and then his daughter and grandson, and all of them are affected. But what you can see is that the grandson is affected at a very young age. John was mildly affected. His mum, in fact, she doesn't have ptosis, but she's blinking in the photograph, unfortunately. So why does anticipation occur? Well, basically, the cause of myotonic dystrophy is an unstable genetic change. So there are lots of other genetic conditions where people have the same change which they pass on to their children. And it doesn't change, so that you would expect brothers and sisters and sons or daughters, if it's a dominant condition, to have it to a fairly similar degree. In myotonic dystrophy, that's not the case. And usually, there are roughly 5 or 13 CTG repeats. That's what the normal number of repeats are. But the CTG repeat is unstable, so first of all, that means it varies in every part of your body. Different cells have different numbers of repeats, so that's what's meant by the term somatic instability. Think of it as just being different variation in different cells. So the blood, muscles and brain will have different numbers of repeats in them, and that's part of the reason why no two people with myotonic dystrophy are affected to exactly the same degree. Why one person may have more problems with their heart, another person may have more problems with myotonia, another person may have more problems with their bowels. Not only that, it changes with time. So what you're born with is not the same number of repeats that you will have 20 or 30 years later, and more particularly, when it's passed on to children, it actually also increases as well. Hi, Mark. So what about the severity of myotonic dystrophy? Well, the normal, you're allowed up to 38, although most commonly, as I said, it would either be 5 or 13 repeats. And then when it gets to about 50 to 100 repeats, that's when people start to get some mild symptoms, either cataracts or mild weakness. The more typical age of onset may be in the 20s, 30s, 40s. People will have anywhere between 100 and 500 repeats. Now, this is what's measured in the blood. It's not telling us what's actually present in the heart or the muscles. And then the congenitally affected children, they tend to have 500 to 2,000 repeats. But if you notice, particularly in those last two, 500, you could either have the classic form or congenital. So there is a huge overlap. And again, probably that's because of the variation in the different tissues. So just to look at that visually, just to give you an idea, so on the top line and the second line down, those are both normal numbers of repeats. On the third group, then that's somebody minimally affected with 55 repeats. Then the next group is 150 repeats, and you can see 150 is a lot more than you should have. And basically, shoving that in the middle of your genes doesn't do them any good. So if you then do this, 1,500 repeats, you can understand why for the congenitally affected children, it really messes things up. It shouldn't be there. So I've mentioned that there's a variation in the different tissues. Another way of calling that is tissue mosaicism. What I want to emphasize here is there was this study done in 2007. I don't want to overemphasize this, but a mother could be typically affected with minimal symptoms, and then there's a massive increase in the CTG repeat from the mother to the next generation. This happens on average 950 repeats increase. So if you think about somebody with congenital myotonic dystrophy often has round about 500 to 1,000 repeats, then when it's passed on from a mother to her child, on average, there is 950 increase in repeats. That's this figure here. There's a bit of variation, plus or minus 800, so that's a big variation. So it could be anywhere between 150 and 1,700, but on average it's 850 repeats. Whereas when it's passed on from a man the average is 56. Or if we round it up, if you pass on myotonic dystrophy from a mother, on average it's 950. From a father, on average it's 55. I sort of apologise for putting it quite so starkly, but that's why we have to think about the next generation with myotonic dystrophy, and many people are not aware of how big that figure is. Another way of looking at it, and unfortunately for most people in the United Kingdom, they don't know, and I don't know the size of the repeat for most people in myotonic dystrophy under my care. Another way of looking at it is if mothers have a CTG repeat of less than 300, 90% of their children won't have congenital myotonic dystrophy, whereas if the CTG repeat is more than 300, then 60% of the children have congenital myotonic dystrophy. Somebody's just asked me, how do we know how many? In the UK, you won't know because it's not measured. In research labs, well, one or two of you might know. There's about 2 labs in the UK that do give the repeat size.
Because my sister was pregnant. She has now the baby. He's not affected because we know before because I had. So she was monitored. And they told her when she was tested and her son was tested, so she was told when they checked the baby inside her, if when she was pregnant, they had this. They did the test with the baby, so the baby was healthy, and then they could tell my sister how many times
the point is it's possible to tell the size of the repeat, but the way the laboratories are set up in the United Kingdom and the standards that they've been told to use mean that most laboratories aren't able to tell you the number of repeats.
It was in Southampton. She was in Southampton.
Yeah, also in the past they used to do it.
We were told from Cambridge, it took about 6 weeks for the test to come through on the number of repeats.
But did they tell you the exact number of repeats?
Yes.
Yeah.
My husband has 75, but my daughter has 600.
Yeah, so you're giving an example of how it changes from 75 to 600.
It's a bigger thing from father to daughter than you would.
Yeah, I mean, I stand by what I'm saying. The majority of, 80% of laboratories in Britain do not give the CTG repeat, but from my point of view and from researchers' point of view, we would want to know it because it does give some useful information. The reason they don't give it is that people are worried that you're going to make too much interpretation of the size of the 75 and the 600 repeat. And there is a danger of that, particularly with people who aren't familiar with myotonic dystrophy, is misinterpreting that information. Don't know where Chris has gone. He's gone now. But if you don't mind, I'll carry on. But the point is that top line there, because of the massive increase in repeat, 99% of children born with congenital myotonic dystrophy are born to mothers, and only 1% are born to fathers with myotonic dystrophy. So what about prenatal? This means that some people would want to find out whether or not their baby is going to be severely affected with myotonic dystrophy or have it at all. So there are different options, and at the moment the commonest options are still amniocentesis, chorionic villus sampling, and cell-free fetal DNA, and I'll just come on to talk about them. So amniocentesis is probably the oldest technique, and what it simply means is taking a sample of the fluid that surrounds the baby during pregnancy. In that fluid will be some cells which come partly from the membranes and partly from the baby's skin, and those cells can then be spun down and can then be cultured. So because they have to be cultured, it basically takes about a fortnight to get the results. So it takes 10 to 14 days after the sample's been taken. The advantages with it is it's safer for the pregnancy. There's a less than 1% miscarriage rate. In fact, it's probably less than 0.5%. They can also do 1 or 2 other tests at the same time, so they can check chromosomes, and if there was reason to be concerned about other things, they can even do things like metabolic tests, and there's usually plenty of sample to test because they've grown it up. The disadvantages of it are that it's at a later stage of pregnancy. It's at around about 15 weeks, and therefore if somebody opted to then go ahead with a termination of pregnancy, they usually have to go through a mini labour, and that can be quite an unpleasant experience for people. CVS stands for chorionic villus sample, but basically what it is, it's a biopsy of the placenta. So you take a small sample of the placenta, and then you have to separate out the two different parts, because the placenta is made up of parts from the baby and parts from the mother, and you obviously need to make sure that you get the part from the mother. And then you can do quite a quick direct test. And the advantages of it are that you can do it at an earlier stage, round about 11 weeks, usually just under 11 weeks, so it's 10 plus 5 days or 10 plus 6 days, but it does vary from which centre is doing it. You can get a result very quickly, usually of the order of 3 to 5 days, occasionally even within 48 hours. And then because of that, you don't need to go through a mini labour. You can in fact have, have what's called a suction termination or a surgical termination. But that still would usually be under general anaesthetic. And of course with myotonic dystrophy, we need to be aware of all of those issues, and the anaesthetists need to be made aware of it. They would do a slightly different chromosome test. They do what's called a direct test, so that would only test the main, what we call trisomies, so that's the Down syndrome, and then there's 2 other trisomies which are tested as well. The disadvantages with it are that it's not quite as safe, so there's a roughly 2% miscarriage rate. They only get a very small sample, and obviously if they don't manage to separate out the mother cells properly, then you can get an inaccurate result. You still need to wait for the results of other tests, and you can sometimes get the all clear on one test, only to be disappointed to find that then another test comes back 2 weeks later showing that maybe there's a chromosome problem. What about cell-free fetal DNA? What I'm trying to show here, so this is the placenta, and then if we zoom in on there, then the baby's contribution has this sort of frond-like appearance. And then floating around outside, this is the maternal blood, but you lose a few cells coming off here. That's naturally what happens as the baby grows, and those cells shed DNA into the circulation. So, in your circulation, you've got the mother's, this is now her blood vessel, and you've got some maternal DNA floating freely, and you've got some baby's DNA floating freely. So the idea of this is, instead of sticking a needle into the tummy, you can stick a needle into the mother's arm and take a sample of, you can get a sample of the baby's DNA. Now that does sound incredible. Halfway down there I've put that it actually only represents, so the baby's DNA only represents less than 1% of the total DNA in the mother's blood. So you can imagine the technology to separate that out from the mother's DNA is quite immense, but it is a test that is now becoming increasingly available. It's only been available since 2012, and to start off with, the easiest thing to do was actually to identify whether or not a baby is a boy or a girl. Because ladies, you don't have a Y chromosome, so if you can identify the Y chromosome, then you know that you're dealing with a boy baby. So most of the time, it's used, the technique is used at the moment for identifying X-linked conditions. So for example, Duchenne muscular dystrophy. So what you might do is say whether or not the baby is a boy or a girl, and then if you know it's a boy, you might go on at the moment and then go on and do one of the other tests. But in the future, what we would hope to do is be able to do direct tests. Are you wanting me to try to...
No, not yet. 5 minutes or so.
Right, okay. Are we trying to catch up with time?
No, just giving you extra.
Okay.
I'm not trying to put you down.
Right, okay. You can do other tests with it, and let's just say that in the future, we are quite hopeful that the test will become more widely available. So although at the moment it is mainly used for X-linked conditions, it's not yet available for myotonic dystrophy, but it's already started to be used for single gene disorders. So I'm aware of it. I think it's in the States they use it for Duchenne muscular dystrophy. It's now used for achondroplasia in the UK, and it's now also used for cystic fibrosis. So I think it's only a matter of time before it starts to be used for myotonic dystrophy. So it's a possible thing, so just be aware of it in the future. Not surprisingly, it's not suitable for multiple pregnancies, because you may have one twin who's affected and one twin who's not, and of course the fetal DNA could have come from either of them, so it's not suitable for things like that. It can be extremely accurate, but there obviously are some risks of error, and because you're dealing with such fantastic technology, there is a risk rate of about 4%. So what about PGD, pre-implantation genetic diagnosis? What you need to know is a little bit of biology. So what we're showing over there at the beginning, so you've got fertilization on day 1, and then by the end of day 2, what you go through is the cell divides into 2, and then later on in day 2, then you've basically got 4 cells as of the very early part of an embryo. And then on day 3, there's this thing called a morula, which is basically a ball of cells. It looks a little bit like a football drawn like that. So that's the image on the left-hand side, which is what's called the morula. Sometimes there may be, say, 16 cells. That's the sort of number of cells. And what they do is they puncture a little tiny hole in the outside of a membrane, and then they pull out one single cell. This is the thing. It almost makes me emotional to think of the technology that's behind here. Basically, have I gone? Here we go. Basically, you have a single cell removed. That's a single molecule of DNA. Now, if any of you have done anything to do with chemistry in the past, you'll realize that one molecule is 23 noughts, or 0.23 noughts of quantity of DNA. It's a tiny amount of DNA. So the technology behind this is awesome. I can't emphasize that. I'm not one known for sort of exaggerating about things. It will vary about how easy you can get access to PGD from region to region. And that's one of the problems. And again, it's this postcode lottery sort of thing. So I can talk about it from what I know happens in Wales, and you will find from different parts of the UK, it will vary. In Wales, in order to have this on the NHS. So I'm talking about this on the NHS. If you wanted to go privately and you had enough money to do this, there would be no question about any of this. But if you wanted to have it paid for under the NHS, you would have to have no living unaffected children. You can have affected children, but if you've already had an unaffected children, then they won't actually pay for you to have it. There's an upper age limit, and again it varies from region to region. Some regions it's 37, other regions it's 39, although that also varies from the centre, not necessarily the region. So you may be penalised at either end of the equation. You need to have a significant risk of a live-born child with a serious genetic condition, which obviously applies in myotonic dystrophy. There is a process of applying, usually for funding from your region, and in my case, I've put WISC there, which is the Welsh Health Specialist Committee, and I end up having to do quite a long application to justify why somebody should be funded for it. I've just given you an idea. So, in fact, in Wales, what they tend to do now is they fund the initial consultation only, because about half the people who decide they want to go forward for it, in the end decide it's not for them. So rather than funding the whole process, they decide to fund the initial consultation. And again, depending on where you go, I've seen figures of £150 in one centre or £400 in another centre. If you go on and have the treatment, then it's £10,000 to £13,000 at least per cycle. So it's not cheap. And in Wales, they will agree to pay up to 3 cycles, but after that, if it hasn't worked, they won't pay for it. They won't pay for any more. And the pregnancy rate per egg collection is about 33%. But if you get as far as actually being able to transfer the embryos, then the rate is quoted at different centres between 40 and 50%, and it's improving all the time. So 3 years ago, you would have probably seen figures nearer to 30%, whereas now the figures are getting closer to 50%, and I don't know, Karen may give you even better figures when she does the workshop. As far as I'm aware, there are centres which basically have now been doing more than 1,500 PGD cycles for 30 different genetic conditions, and myotonic dystrophy is one of the licensed conditions, so it is available now, and I've had quite a few patients who've gone forward with it. So basically, to summarize, myotonic dystrophy, obviously there is the potential and a high risk of having a child with congenital myotonic dystrophy, especially if the mum is the person who's affected. There are a number of different options available. All would require referral to clinical genetics, ideally before somebody becomes pregnant, because obviously you can start to work things out. And then there are options such as either prenatal diagnosis or PGD. Thank you.